Good evening, dear students. Welcome to the live session. And as the theme goes, human anatomy made simple. Today we are going to discuss some of the questions which are high yielding, and they will be helping us to prepare for the coming exam, INI-CET, and not only the this particular exam, but also FMGE, All India PG. Now, and of course, like I'll try to look into the chat also. Good evening, sir. Yes, good evening. Welcome you all. So, briefly, let me just tell you some of the facts when you are working for the competitive exams. As we understand, the importance of previous year questions is paramount. So, when it comes to the approach for your PG entrance exam, the best approach is to know that more than 70% of the questions will be from the repeat topics. So, it is obvious that you are supposed to go through previous year questions. Last 15 years will be good, but at least the last 5 years, because the pattern keeps changing. As you know, if it comes to anatomy, what they have started doing is giving you some dissected specimens and clinical oriented questions. So, latest pattern is important, and but as you go through those previous year questions, you will come to know about the hot topics. Once you work upon those hot topics, you are making sure you are getting more than 70% scoring, and more than 70% means you will be in the top notch, maybe 100 students. So, this is what I can tell you. Practice as many MCQs as possible. Now, moving further, you see, when we used to prepare, there was a famous saying, majority outside. I will tell you one incident. We used to prepare in a group, and there was one senior also preparing along with us, and after giving our AIMS exam, we were sitting together and just discussing that what questions were there, what answers were there, and we were 4 of us, the 4th himself being there, and whatever answers we were telling, like A, B, C, D, C was the answer, or this particular choice was the answer, he was giving some other option as the answer. So, 3 of us giving one answer, and his answer was all the time different. So, we could immediately make out that we are not going to have a good rank. This is the person, the senior is going to have good rank, because majority outside. 75% of us, or maybe 90% of us, will always mark our answer as on the distractor. There is always a distractor. You know, like we have 4 choices, A, B, C, D, and if we are prepared quite well, immediately we will root out that these 2 cannot be the answers. We are stuck with 2 of them. In those 2, the answer, let us assume, is B. The C is a distractor, and most of the time 90% of the students will answer C, the distractor, and majority are outside. There will be very few, only 10% will mark the exact answer. So, majority outside. This you have to understand. You have to understand the psychology of the examiner, and then only we can get a rank. Anyhow, that is my experience, which might help you. Now, in the same context, you will find that we are having this MCQ marathon. We are going to discuss the previous year questions with the same view that some topics are important, like yesterday Dr. Zainab has already taken care of radiology, today anatomy, tomorrow it will be Dr. Marwa taking medicine. So, it is a sequence, you will find that on YouTube. So, it is my advice that kindly attend all those sessions, that will be helping you a lot. Let me look at the chat as well. Apply type questions, yes, of course. after a long time? Yes. Right. So let us continue. Now I am starting with one of the question which has appeared lately, but I have modified it a little bit. So I am asking you, what could be your answer? This question is basically asking the nerve supply to the type of papilla which is shown in the microscopic picture of tongue. So tongue will have some papilla with some taste buds, and you have to identify which type of papilla. Once you identify the type of papilla, then you have to tell which nerve is supplying there. So is it mandibular branch of trigeminal, facial nerve, glossopharyngeal, or vagus? Kindly write down your answers in the chat. Let me see how many of you, the 10% of you, will be giving me the correct answer. FMGE, yes, it is. See, this kind of, may it be FMGE or All India PG, or may it be INI-CET. Recently there has been overlap of all the questions. Whatever we teach, it is for all the exams basically. So everybody should attend and will be benefited. So what do you think is the answer? B, C, B, C, D, B, C. First of all, you have to identify which papilla is this. So though, because it is a short session, I will not go into details, but let me tell you, this is the largest of all the papillas in our tongue, and it is having lots of these pale areas, and these pale areas are the taste buds. Papilla is a connective tissue which is a core of connective tissue lined by its stratified squamous epithelium on the tongue, and a lot of taste buds, as many as 250 taste buds in one particular papilla. This is the circumvallate papilla. And as you talk about circumvallate papilla, how do you identify it? First of all, it is the largest of all, because there could be other papilla also, foliate, and then there is this filiform, there is the circumvallate is here. So let me show you the types also, but one thing is, it will have a pit here. You see there is a pit here, and then there will be a wall in the periphery, and this wall in the periphery is circular wall, circumvallate, with the pit. In the pit there will be some glands also giving the secretion, serous glands of von Ebner. The other thing is, if it is a circumvallate papilla which we have identified, which nerve is going to supply? Let me show you another diagram for the same purpose, and as you will notice here, embryologically we have to remember, when we are looking at the tongue, and let us say this is the sulcus terminalis. Embryologically, the sulcus terminalis is separating anterior 2/3 of tongue from posterior 1/3 of tongue, and anterior 2/3 of tongue, which is developing in the first pharyngeal arch, will be having sensory supply from the first pharyngeal arch nerve, that is mandibular nerve, but the taste sensation will be carried by cauda tympani nerve, branch of the facial nerve. So anterior 2/3 of tongue, taste is carried by the cauda tympani nerve, branch of the facial nerve. What about the circumvallate papilla? They are located here, as you can see. These are the circumvallate papilla, as you can make out, and these circumvallate papilla, though they are located in the anterior 2/3 of tongue, embryologically they have migrated from the posterior aspect here, which is basically, if you are talking about the posterior 1/3 of tongue, it is developing from the third arch, and glossopharyngeal nerve is supplying there. So third arch nerve, glossopharyngeal nerve is supplying the posterior 1/3 of tongue. What about the posterior most tongue? If you talk about the posterior most tongue, which is also the nerve supply to the epiglottis, this is arch number 4, and you have superior laryngeal nerve, branch of the vagus. So tongue developing from the first arch and third arch and the fourth arch. Second arch disappear from the tongue. Now the thing is, this circumvallate papilla, though it is appearing in the anterior two-third, would have embryologically come from this region, carrying the nerve supply there. Ninth nerve, glossopharyngeal nerve. So our question was having circumvallate papilla, which is histologically to be identified, and the nerve supply will be glossopharyngeal nerve. That should be your answer. Now, because the session is short, I cannot spend much time on a single question. So let us proceed further. This is one of the typical questions which the examiner is asking quite frequently. So what do you think is the answer? Receptor which is responsible for the blind people reading Braille, and it is one controversial topic, you know, all of you know. So which one will you choose, Mesner or Merkel? Kindly mention in the chat. Let me give you some details, but understand that in this particular question, the answer should be Mesner. A is a better answer than B. Now, why is that so? Let me describe it further. As we move further, you will find this is the skin which is showing the four type of receptors, and two of them are rapidly adapting, two of them are the slowly adapting receptors. So there is one which is called Merkel cell, and Merkel cell which is in the basal layer of the epidermis. You will notice here this is the location where you will have Merkel tactile disc, and it is in the basal layer of epidermis, slowly adapting receptor, but is very precise. You can notice here it is very precise, and the most precise to detect the Braille dots. It is the most faithful receptor to detect the Braille. If you come to the next one, which is Mesner Corpuscle, which is at the dermo-epidermal junction, you will notice it here. The Mesner Corpuscle is located here. This one is the Mesner Corpuscle. At the dermo-epidermal junction is also for 2-point discrimination, but is rapidly adapting. Now, if it is rapidly adapting, this is slowly adapting, which one do you think will help us in reading Braille? If you are trying to learn the Braille, you will use the Merkel cell. This is just the beginning, you are just learning, then Merkel. But once you are reading fast, usually 3 fingers are used. So once you are reading fast, you have to look at a rapidly adapting receptor, which is the Mesner. So maybe in the beginning, when you try to learn the Braille, the most specific receptor is Merkel, but Merkel cannot help you in reading the Braille. See, you don't read words, you read sentences, and to read sentences you must be working fast. That is why the Mesner Corpuscle is always a better answer for reading Braille. I told you Mesner is a better answer than Merkel. What about this Pacinian Corpuscle, which is mostly for pressure and vibration? And what about this Ruffini, which is for dermal stretch? The Ruffini is slowly adapting for dermal stretch in the deep dermis, and Pacinian is rapidly adapting for pressure and vibration in the deep dermis. If you look at their distribution, Pacinian broad, Ruffini still broader. So they cannot identify the dots which you are using in Braille. Most precisely is Merkel, but Merkel cannot help you reading Braille because you have to read faster. This is a slowly adapting receptor. I hope this will clear some of the doubts, or let me ask you another way. What do you think is the answer to this particular question? Which of the following is faithfully representing the Braille character? What do you think? Now what is your answer? Faithfully representing the Braille character. Here, this is a different question, and you have to answer it as Merkel, because Merkel is most precise. So there are two questions. Number one, which is the most dependable for reading the braille dots? Merkel. But which one the blind people actually use for reading braille, because you're reading faster? That time you have to change your answer to Mesner. So be careful, for such a question your answer is Merkel. But if simply asked, which receptor do you use for braille, then you have to answer it as Mesner. Rapidly adapting, you read fast, isn't it? This slowly adapting receptor cannot help you in reading braille, though it may be the most precise to read braille. Now, as we move further, you see, this is one question they have asked, and these are repeatedly asked questions we have to be very well versed with. Like this is asking, which type of collagen is found in the joint capsule? Now, there are a lot of types of collagen, but specifically focus upon 4 of them, and since it is a joint capsule, they must be asking about the synovial joint. So what do you think? 1, 2, 3, 4. Type 1 is the most common, we know, and can be seen in the bone. Then what about the cartilage? Cartilage, mostly it is type 2, but be careful, because we are talking about hyaline cartilage and elastic cartilage. So if it is hyaline and elastic cartilage, it is type 2, not the fibrocartilage. What about the fibrocartilage? Fibrocartilage is a typical cartilage, and we have to remember that if it comes to fibrocartilage, then predominantly it will have type 1 collagen. Now here I'll add one more thing. Type 1 collagen, which is the most common type of collagen found in bone and fibrocartilage, is also found in capsules. And when you say capsule, which type of capsule are you talking about? The organ capsule, even the capsule. What is capsule? Covering. So even the covering of bone, which is called as periosteum. So covering or capsule of the bone, which is periosteum, will have type 1 collagen. Even the covering of cartilage, the perichondrium, will have type 1 collagen. So just try to memorize this information. Type 1 collagen is found in bone and periosteum. It is present in fibrocartilage. It is present in the capsule of the organs, and even perichondrium has type 1 collagen. If somebody asks you hyaline cartilage, elastic cartilage, which collagen? Change your answer to type 2. Where do you see type 3? If you are talking about type 3 collagen, then you will find it can be seen in some lymphoid organs. It is also called as the reticular fibers. So type 3 collagen reticular fibers like lymphoid organs. Type 4 you will find in basement membrane, like in the kidney you have basement membrane. So just to try to remember these facts. Now let me come back to the question. Like you will find we have got a diagram here. This diagram is telling us about a synovial joint, and let us assume that we are talking about knee joint. So if you are talking about the knee joint, there will be a upper bone, the femur bone, which is male surface, and a lower bone, which is tibia bone, the female surface. Now, since it is a synovial joint, it will have a capsule, and this capsule, as you notice, is connecting the bones, femur with tibia. And this capsule as such, which type of collagen is there? That was our question. Understand that we already have mentioned, if we are talking about periosteum, which is covering the bone, which type of collagen is that? Periosteum is type 1 collagen, and it is continuous with the capsule. Capsule is which collagen again? It is again type 1 collagen. So periosteum, which is continuous with the capsule, both of them are type 1 collagen. Understand, when the bone comes into the joint, the periosteum will be missing. You don't have any periosteum, or the bone when it is lying by cartilage, say articular cartilage, which is mostly hyaline cartilage. If you are looking inside a joint, say this is articular cartilage, which is hyaline cartilage, normally it will have perichondrium, but inside the joint it has no perichondrium. You do not have any perichondrium or periosteum inside the joint. Intracapsular, you do not have periosteum or perichondrium. By the way, can you tell me what is the type of collagen for articular cartilage? And as you see, articular cartilage is mostly hyaline, so which type? It will be type 2 collagen. So if it is articular cartilage, is type 2. What about the knee meniscus? Say this is intra-articular disc, the knee meniscus, fibrocartilage. And if it is fibrocartilage, then atypical cartilage, type 1 collagen. So we have learned some details here. Number 1, what is periosteum? Collagen, type 1. What is capsule? Type 1. What is perichondrium? Type 1, but it is not inside the capsule. What about the articular cartilage? Which collagen? It is type 2 because mostly it is hyaline. What about the fibrocartilage? Is it atypical cartilage, type 1 collagen? So just memorize all these facts because they are repeatedly asked questions. Now we are moving further, and this is one question which came recently, and I want you people to understand the concept behind it. It's a neuro question. Fibers carried by the marked structure is lesioned, and at the level of red nucleus. Red nucleus is midbrain, upper midbrain, and it will result in which of the following? So that was a question. Let me just look at the chat also. Normally I get so engrossed in teaching, I lose contact with the surrounding the students, but anyhow, if the purpose is being fulfilled, no issues. So first of all, let us understand that what exactly are we pointing towards. They are just asking ipsilateral cerebellar lesions or ipsilateral contralateral cerebral features. So let me just magnify this diagram, and then we can talk about the details. As we know, this diagram is basically a posterior view of the brainstem, and cerebellum has been removed. So posterior view of the brainstem, cerebellum has been removed. Cerebellar peduncles we are focusing upon, and here, as you will notice, let me put the details. Say this is, if you are looking from posterior view, and if you remove the cerebellum, you would have cut the peduncles, 3 peduncles, and this is basically superior cerebellar peduncle, which the pointer is looking at, marking. And you can see here also superior cerebellar peduncle. Middle is towards the pons, and let me mark that as well. See, this is going to be the middle, which is towards the periphery here. I think I am coming in view. So this will be the middle, and then there will be one inferior also. Let me mark the inferior as well. Somewhere here will be the inferior. And you can see that here as well, superior, middle, and inferior. The thing is, say you are talking about this person walking in a straight line. When you are walking in a straight line, your legs are moving, there will be a tract starting which is called as Spinocetibalar Tract, and that Spinocetibalar Tract is bringing the information to the ipsilateral cerebellum. Now this information which comes via the spinal cord into the ipsilateral cerebellum will be interacting with some of the cells and some nuclei, like there will be a dentate nucleus, and from the dentate nucleus one tract will begin, because all the information must go to cerebrum eventually. Relay centris thalamus, so it will be using the thalamus, but the fibers are crossing before it reach the thalamus. So let me show this here, like this is Spinocetibalar Tract on the right side, because you are looking from posterior view, carrying the position sense of the lower limb, and coming to cerebellum dentate nucleus, a tract will start, dentatorubro-thalamic tract. Now this dentatorubro-thalamic, the name is telling, from dentate nucleus to the red nucleus of midbrain and to the thalamus. From the thalamus it can go to cerebrum, the higher brain center. Where is this crossing of fibers happening? Or a question comes, superior cerebellar peduncle, which carries dentatorubro-thalamic tract, where is the decussation of the superior cerebellar peduncle? And your answer will be at the level of inferior colliculus in the midbrain. You can see here the other details, like this is superior colliculus, this is inferior colliculus in the midbrain. Upper midbrain, superior colliculus, lower midbrain, inferior colliculus. So this crossing of fibers is happening at the level of inferior colliculus. Where is red nucleus? Red nucleus is at the level of the superior colliculus. So the thing is, if there is a lesion at the level of red nucleus, which is basically the level of the upper midbrain, where will you find the problems? The fibers have already crossed. So the lesion, if it is on the left side midbrain at the level of red nucleus, then where will the problem will be? Contralateral cerebellar problems. So superior cerebellar peduncle they are marking, which crosses at the level of inferior colliculus, that is lower midbrain, and if it is lesion at the level of upper midbrain, which is red nucleus, dentatorubro-thalamic tract will be compromised, and wherever the lesion is, problems will always come contralateral. So there will be difficulty in walking in a straight line for which leg? The right leg. Lesion is left, problem will be on the right side, and that was our question. Contralateral cerebellar problems. What about the cerebral problems? Cerebrum, if you talk about cerebrum, then it is not passing through the cerebellar peduncles. There are cerebral peduncles. So there are cerebellar peduncles, there are cerebral peduncles. This was about the cerebellar peduncle. Again, because we have limited time, we cannot continue discussing this topic for a long duration, but I hope you got my point, that what I wanted to convey. There are a lot of details, but I'll skip them here. This is one typical type of questions which are coming, like you see. This is a question asking the nerve which is supplying this particular muscle is compromised in which syndrome. This is a superior view of the cranial cavity you are looking at, and the marker is at a muscle. The eyeball is seen, the nasal cavity is seen. Eyeball, medially they are marking, so medial rectus. And if it is medial rectus, then you know, according to the formula of the eyeball, third nerve, oculomotor nerve. So the nerve which is supplying medial rectus, oculomotor nerve, is compromised in which syndrome? That is a question. See, I would like to tell you one thing. Recently, may it be INI-CET exam, FMGE exam, or even the NEET PG exam, everywhere they are giving you dissected specimen, point 1. Point 2, they don't ask you to identify the structure. That is part A of the question. They will always ask you to identify and then give a question beyond that, like here. Of course, you have to identify it is medial rectus. You have to know that it is third nerve, but third nerve is lesion in which syndrome? And then you have to know about the syndromes also. So I hope you know Weber syndrome is a lesion at the midbrain at the level of superior colliculus. So from the superior colliculus level comes the oculomotor nerve. In Weber syndrome, there is lesion of oculomotor nerve, and that is why in Weber syndrome, say if a patient has Weber syndrome on the right side, the right oculomotor will be compromised. The right eye will go down and out, fixed dilated pupil. So fixed dilated pupil, partial ptosis, and down and out eye in Weber syndrome. Medial rectus will be compromised. If medial rectus is compromised, you cannot take the eye in, it will go out, because you know the formula LR6SO4. So that is why if the third nerve is not working, sixth is more powerful, it will take the eye out, and superior oblique will take it down and out. That is why down and out eye, due to unopposed action of oculomotor nerve. Anyhow, why not perinode? Because perinode syndrome, maybe it is also midbrain lesion, but it is more posterior and it is not affecting the third nerve. Then why not foveal? Foveal is actually pons. So pons, you don't have third nerve coming from there. The foveal will be involving sixth nerve maybe, and it will be lateral rectus. And for foveal, the marker will be here on the lateral rectus. See, this is lateral rectus, that is medial rectus. So pointer was on medial rectus, third nerve, hence Weber. If it was on the lateral rectus, then maybe you can choose foveal. And what about Wellenberg? Wellenberg is medulla oblongata, and now number 9, 10, 11, 12. And now number 9, 10, 11, 12 do not supply the eyeball muscles. I hope you got my point. Answer should be Weber syndrome here. Now as we proceed further, this is one of the question. A patient is presenting with diplopia, and now on investigation you found there was an aneurysm and it was on posterior communicating artery in the circle of Willis. So which of the following nerve is most likely involved? You must have seen recently a question has come similar way, that if there is an aneurysm on the anterior communicating artery, optic chiasma can be damaged. If optic chiasma is damaged, there can be bitemporal hemianopia or tunnel vision. So such kind of questions you must practice. What we do is we will always practice the question, understand which topic is being asked, and explore the topic. Keep going around the topic and increase your sphere of activity, because next time the same question will not come. Examiner is always going to twist it, and if we just memorize, mug up the answer, we'll just mark the same answer. That's not going to help us. Anyhow, what do you think? Posterior communicating. If it is anterior communicating artery, then it will be the second nerve or optic chiasma involved. It is posterior communicating, the question is asking, so which nerve? Not the optic, this time it is oculomotor nerve. Now if you say oculomotor nerve is your answer, let us look at the diagram, base of the brain, inferior surface of brain, circle of Willis, and find out that how the oculomotor can be affected if there is a problem with the posterior communicating artery, or if there is an aneurysm there. Now for the same purpose, let us use this diagram, looking at the base of the brain and trying to discuss the circle of Willis, and there you can understand. Let us try to find out the details here. You see, this is the optic nerve from inferior aspect, and this is the other optic nerve. This is the optic chiasma here. Let me use the other pen. So optic nerve, optic chiasma, and then optic tract, optic tract. This is the pituitary, midline pituitary. We know that if there is a pituitary adenoma, it can compromise the optic chiasma, leading to bitemporal hemianopia, the tunnel vision. Now what about the circle of Willis? Can you represent the circle of Willis here? You see, circle of Willis is contributed by internal carotid artery and vertebral arteries. So let us start from the internal carotid arteries here. Let us put the internal carotid arteries first. Say this is internal carotid artery on either side, because you are looking from the inferior view. This is right sided internal carotid, left sided internal carotid. Internal carotid will give you 5 branches, and out of those 5 branches, one is anterior cerebral artery going anteriorly towards the cerebrum. So you can mark the anterior cerebral artery here. Now this is the anterior cerebral artery on right side, and similarly you can show anterior cerebral on the left side as well. It is understood that if we are having an aneurysm on the communicating artery, which is basically the anterior communicating artery. If you have aneurysm on anterior communicating artery, which nerve is involved? Could be optic nerve or more specifically optic chiasma. That was the recent question. But here we are not talking about anterior communicating artery aneurysm, we are talking posterior communicating artery aneurysm. So let us represent the posterior communicating here. This is the posterior communicating artery which is coming. Now, where is this posterior communicating artery going? This posterior communicating artery is going to anastomose with posterior cerebral artery. And where is this posterior cerebral artery coming from? Vertebro-basilar system. You have two vertebral arteries forming the basilar artery, vertebro-basilar system, which will then give posterior cerebral, and this posterior cerebral will have the anastomosis of posterior communicating. Let me show that here. You will find that there is this basilar artery coming, or you can say vertebro-basilar artery system running on the base of the pons, and this basilar artery is bifurcating into two branches which are the posterior cerebral arteries. Now, as these posterior cerebral arteries are going, they are having an anastomotic branch from internal carotid artery. The one which we were just showing here, let me bring it here. So this is the internal carotid artery giving posterior communicating artery, which is anastomosing with the posterior cerebral on one side, and you can show it on the other side as well. Now, what about this nerve which is shown here, and another nerve which is shown here? You will find these two nerves which we are looking at. Let me mark them. This is the thinnest cranial nerve we have got. You can show it on the other side as well. Thinnest cranial nerve, that is the trochlear nerve, and along with that, that is the fourth nerve. Along with that, you see third nerve also. This is oculomotor nerve. So this is the oculomotor nerve, and on the lateral side, this is the trochlear nerve. Now my point is, if you read literature, they'll tell you whenever there is aneurysm of posterior communicating artery, the most commonly damaged nerve is third nerve. So oculomotor nerve is compromised in aneurysm of posterior communicating third nerve. Anterior communicating, it is the second nerve which is involved. What will happen if there is aneurysm on posterior communicating involving third nerve? What will happen? Again, down and out eye, unopposed lateral rectus, unopposed superior oblique, plus there will be partial ptosis, there will be fixed dilated pupil. All those are features of oculomotor nerve palsy. So I hope you got my point. Now, as we are moving further, this is one of the questions which has come recently, but I have modified it, and you will ask me, sir, why have you modified the question? MBBS first year, MBBS first year. Don't worry, if you are in MBBS first year, you still have 4 years to go, but you must be oriented. Maybe it is too much for you, I can understand, but this session is for the people who are going to give your exam, INI-CET exam in fact. So it is at a higher level, of course, and these days I'll tell you, for INI-CET, the PG, whatever exam you are talking about, there will be always dissected specimen in anatomy, there will always be a clinical history, they will not ask you direct question, they will give you point A and then point B you have to answer. So what do you think is the answer? A patient, here a patient has been admitted with skull base trauma, and they already told that ninth nerve is gone, glossopharyngeal nerve has been compromised, and physician is touching the marked structure. First of all, you have to understand what is this marked structure, and then it has resulted in its elevation. So whichever structure you were touching, it got elevated. This is a sagittal section of the head neck region, the lower lip, the upper lip, the hard palate and soft palate. You are talking about the soft palate. This is the tongue here in the oral cavity, the epiglottis here. So if you are touching the soft palate and soft palate is contracting, getting elevated, that is what the examiner is asking. Efferent lymph means sensory. Which is the sensory nerve for this reflex? First of all, what reflex is that? Take one stimulator, stimulate the uvula, the soft palate, and uvula gets elevated due to contracture of the soft palate muscles. Then which nerve is sensory? All of you will say glossopharyngeal, because this is the territory of glossopharyngeal. We understand what is the anterior 2/3 of tongue sensation carried by? First arch mandibular nerve. What about the posterior 1/3 of tongue sensation carried by? Third arch glossopharyngeal nerve. And that third arch glossopharyngeal nerve, not only posterior 1/3 of tongue, but also the soft palate, tonsils, posterior pharynx wall, all this area. So posterior 1/3 of tongue, the soft palate, the tonsil area and the posterior pharyngeal area. That is what you gag reflex. This is gag reflex. You touch the soft palate or posterior tongue or the tonsillar area or the posterior pharynx wall. What do you expect after that? Ninth nerve is activated, sensory, and it will take the information to nucleus tractus solitarius. So this is the sensory nucleus which will receive the sensation. It is general visceral sensation, GVA, neural column, general visceral sensation. Once the information reaches there, it will activate the next nucleus, which is nucleus ambiguus. And nucleus ambiguus is the motor nucleus controlling muscles of palate, pharynx and larynx, which will help in speech and swallowing. So contraction of the palatal, pharyngeal, laryngeal muscle will occur. That's why the soft palate was getting elevated due to that contraction. And it's a motor nucleus. Which nerves are involved? Now number 9, 10, 11. In 9, 10, 11 also, which is the major nerve, the vagus, 10th nerve. So this is going to be the efferent or the motor nerve. Which is the efferent? Efferent is of course 9th nerve. Now if it is 9th nerve, it is already lesioned. 9th nerve is already lesioned. Then how come this reflex is still working? And that is what is called as paradoxical gag reflex. And what is paradoxical gag reflex? Why the gag reflex is still working when the 9th nerve is already compromised? Because that's where you read the books. Even the trigeminal nerve, the palate, which nerve is there in palate? Palate is maxilla, maxillary nerve, trigeminal. So maxillary nerve, which supply the hard palate, also supply the soft palate partially, or to tell you, soft palate has double sensory supply. Which is the major supply? 9th nerve. And what is the minor supply? Maxillary branch of trigeminal. Are you trying to say that maxillary nerve branch of trigeminal is still working? Yes, that is the essence of this question. Your answer is maxillary nerve was still working. This is what you call as paradoxical gag reflex, still working because of this nerve, because it is a partial supply to the soft palate. Now this may become too much for, of course, a first year MBBS student, but you know, after passing your MBBS, after doing your ENT, MD degree in ENT, then these things become quite habitual of yourself and things will come. The only issue is examiner before giving you MD degree. He wants you to be prepared for it. Already it appears like, because these kind of questions should be asked by MD, somebody who is doing MD final year ENT, now they are asking such question, it is understood, but they are asking post MBBS. And why they are asking such questions to post MBBS? Population. There are 2 lakh students. How many seats are there? 10,000. You mean to say 5% selection rate. And if you want to majority outside, And how will you send the majority outside? Everybody in MBBS is well read, they are well prepared. How will you sort out 5% among them? By asking such questions only. And because it is a necessity for the examiner to screen the population, it is a necessity on your part to read such details. Before you actually get an MD seat in ENT, you already are one MD specialist before entering MD degree learning period. Anyhow, so these are some of the details which I'll not go into as such. Let us just proceed further. This is, and what I'm trying to tell you is, these are the latest questions which they have asked. They'll keep asking. See, what happens is, the students, they give us recall of the question, which is not perfect. They'll give something which will cook up and will prepare a question. Then there are so many experts in India. Somebody who has just passed the MBBS and he has just entered first year MS Anatomy or first year MD Radiology, they become expert. They take all the question, give all the answers. They don't understand that the person who has prepared this question has 50 years of experience in anatomy or ENT. They are preparing such question. You are definitely going to tell some wrong things to the students, and you will confidently mark your answer wrongly. So you have to be careful, very careful. You should learn from people who are experienced. You cannot trust on anybody, any Tom, Dick and Harry and coming and just teaching. See, it's been 20 years for me to teach, continuously teaching anatomy. I'm apprehensive that I might tell some wrong statement. Reading Gray's Anatomy from 36th edition, 36, 37, 38, 39, 40, 41, 42. I have all the editions of Gray's Anatomy. Still, I'm so fearful that I might speak some wrong sentence. And these people who have just passed MBBS and they're so confidently telling everything. Don't trust these people. They will be dangerous for us. Anyhow, just a word of caution. So this patient underwent removal of the submandibular salivary gland, very frequently asked question, and lingual nerve is damaged. Now, lingual nerve is topographic nerve, and it is also the functional fibers which are passing through that. If lingual nerve is damaged, not only the sensations which are carried by lingual nerve, but also some of the secretomotor fibers will be compromised. So which of the following statement is not correct? You have to tell a wrong statement. Lingual nerve, first of all, is a branch of mandibular trigeminal. But if this is the nerve, it has a lot of axons. It also carries the axons from the facial nerve, cauda tympani nerve. And that facial nerve, cauda tympani fibers, postganglionic fibers, carried by lingual nerve to control glands like submandibular salivary glands, sublingual salivary glands, they will also get compromised. What is the mandibular trigeminal nerve doing? Journal sensory to the anterior 2/3 of tongue, developing from first arch. But then this facial nerve features will also be compromised. Cauda tympani has one more function. It also carries taste sensation. So taste sensation from anterior 2/3 of tongue, which is carried by cauda tympani, is topographically related with lingual nerve branch of mandibular. If you damage lingual nerve, then of course fibers of facial nerve, postganglionic fibers, cauda tympani nerve fibers will also get compromised. So the point is, if you have damaged lingual nerve, which can happen, see, this is a submandibular gland, there is a duct, hooking under the duct is lingual nerve, it might be damaged. What do you think is the answer then? Sublingual gland secretions are reduced, yes, as I mentioned here, secretomotor fibers. What about the anterior 2/3 tongue, taste sensation? Yes, cauda tympani nerve. What about the sensation at the floor of the mouth? For the mouth again, it is lingual nerve, mandibular trigeminal. This is not fitting well because this will be a problem of 12th nerve. So can't the 12th nerve be damaged here? Of course 12th nerve can also be damaged, but they have already mentioned in subglandular submandibular salivary gland there. Which is the most commonly damaged nerve? Lingual nerve, which is next in number, hypoglossal nerve, and which is the next nerve. There are 3 nerves which you can talk about, but anyhow this will be 12th nerve features, so it goes out of, see, not correct means incorrect statement, choice number D. Let me just tell you one detail here. If you are talking about submandibular gland dissection and you are operating upon, see, the facial nerve, which is giving 5 branches here. You can see the branches like facial nerve will come from stylomastoid foramen, enter the parotid gland, give 5 branches, and 5 branches for facial nerve are, there is one going upward, temporal bone, temporal branch, one is zygomatic bone, zygomatic branch, one is the buccal branch, one is marginal mandibular, because this is mandible margin, this is the one which supply the lower lip, and you will see a lot of questions coming on this branch, marginal mandibular branch of facial nerve, they are asking. And which is the 5th one? The cervical branch of the facial, which supply platysma muscle here, subcutaneous muscle here, cervical, marginal mandibular, the buccal, zygomatic, temporal. So these are the 5 branches. Which is the one compromised in while you operate on the submandibular gland, gland under the mandible? And this gland, which is under the mandible, submandibular gland, the nerve which is compromised more often is marginal mandibular branch of trigeminal. If you compromise it, lower lip will be having paralysis, drooping of lower lip. So the point is, how do you prevent that? You have to put the incision in such way which is 2 to 3 centimeter along the marginal mandibular nerve, means this is the margin of the mandible, you go 2 to 3 centimeter below, and there you put the incision line. You are not supposed to include this branch or the other branch. You have to avoid cervical as well as marginal mandibular. Conclusively, a question has come. Question number 1. When you operate on submandibular gland for excision, which is the most commonly damaged nerve? Answer is marginal mandibular branch of facial nerve. Question number 2. When you are working on submandibular gland excision and you are ligating the duct of submandibular gland, which nerve is damaged? If you specify duct of submandibular gland, hooking under that was lingual nerve. So that time your answer will be lingual nerve. And which is the 3rd nerve which can be damaged? Even hypoglossal nerve can be damaged. Let me show you the diagram for that. Both of these nerves, you must have seen these diagrams. Like one student is asking, sir, I am first year MBBS, what are you teaching all these details? They are useless for me. Do you see this diagram in BD literacy or not? They are there. So this is the submandibular gland, and it is having 2 parts. There is outer superficial part, deeper smaller part. From there a duct is coming, the submandibular duct. Hooking under that is the lingual nerve. So this was our question actually, what they were asking. Lingual nerve branch of the trigeminal, which is hooking under the duct. If you are working on the duct, you can damage the lingual nerve. What will happen if you damage the lingual nerve? Number 1, sensation to the anterior tooth or tongue will be compromised. And number 2, there will be loss of taste sensation because it also carries the fibers of chorda tympani. Number 3, you will have the problem with the sublingual salivary gland mostly because the fibers will be compromised, chorda tympani fibers again. So some of the details, let me just move on because again cannot continue with the same questions for a long time. Now this is one typical question which has been appearing quite frequently, and despite teaching it very often, still we keep answering it wrong. This is about the lumbar puncture, you know which structures you are going to puncture, but a second pop sensation has come. So you have penetrated which of the following? Durameter, pyometer, acrometer, the meninges, or a ligament here. If you read anesthesia books, they'll mention only one pop sensation. But there are some books which will mention the second pop sensation. So what do you think could be the answer? Let me just go through this chat also. Dura. Okay, fantastic. If you could answer it as Dura. You are all well-read people, I know. Now the thing is, as I told, what is the recent pattern of examination? They'll always give you dissected specimen, clinical oriented questions. This is the latest pattern. Let me take you to one such diagram now. And you see here, this is the diagram. And what we are looking at is, say, this is where you are pushing the needle, either L3-4 vertebra or L4-5 vertebra. And when you are pushing this needle here, this is the needle, what is the structures you are going to puncture? That is what the examiner is interested in asking. Obviously, the first thing is skin. And after skin, you'll have the superficial fascia. And after superficial fascia, so the first thing is skin, and then you have the superficial fascia. After that, the needle which you are talking about, you see this is the needle here. So skin, superficial fascia. Then comes 3 ligaments which are related with the vertebra. You will find this is the vertebra here. Let me mark the vertebra. This is the body of the vertebra, and this is the spine of the vertebra. As you see, this is body of the vertebra anteriorly, this is the spine of the vertebra. And you can show one more. This is the upper vertebra now, body of the vertebra, and this is the spine of the vertebra. Now the thing is that you are going between the 2 vertebra, maybe L4-5 vertebra. Between the vertebra you have 3 ligaments, and their names. Their names are, as we know, supraspinous ligament connecting the spine with each other. Here you will have supraspinous, and between the spines you will have interspinous. So here interspinous, and then you have the lamina of one vertebra connecting with lamina of other vertebra, ligamentum flavum. So the third ligament is ligamentum flavum. Now the point is, when you were pushing the needle, you had 3 ligaments. There will be resistance. You are pushing the needle, resistance, 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 because you are passing through supraspinous, interspinous, ligamentum flavum. Sudden loss of resistance as you puncture ligamentum flavum, and that is called pop sensation. Sudden loss of resistance after puncturing ligamentum flavum, that is pop sensation. So this is the first pop. Now, because you are doing lumbar puncture, you have to puncture meninges, and as we know, say this is the spinal cord here, and it is covered by dura mater. And what is inside the dura mater? You will have the arachnoid mater, and you have to go deep to the arachnoid mater because you have to go to subarachnoid space. Basically 2 meninges you have to puncture. So this needle, when was the first pop sensation? When you punctured the ligamentum flavum. When will be the second pop sensation? See, you are continuously pushing the needle now, you will get resistance again. Why? Because this time your needle is going to puncture the dura mater, and once you puncture the dura mater, another sudden loss of resistance will come. Second pop sensation comes when you puncture the dura mater, and of course arachnoid mater is very thin, no resistance. Immediately you will go into subarachnoid space, you can aspirate the CSF and give the inject the anesthesia agent, but the second pop sensation comes when the dura mater is punctured. Question can come, when do you get a pop sensation while doing lumbar puncture? So which one should you take as your answer? The ligamentum flavum or dura mater? If you have only single question like, when do you get the pop sensation? After puncturing what? Your answer should be ligamentum flavum. And if it is not in the option, second answer or second pop is because of puncturing dura mater. So that was the purpose of this question. Now, as we proceed further, this is one question which has come recently. See, all these questions which I am discussing here are latest questions, but I have slightly modified them because examiner will also do the same. And somebody might ask me, sir, how do you know that? I gave my All India PG, AIMS PG, PGH Chandigarh, JIPMER, NIMHANS exams in year 2000. It's been 21 years and I haven't forgotten those nights when I was preparing for the exam. 21 years I have not forgotten, and that is why I am still good at teaching for PG entrance exam, because I have never forgotten the pain, the problems. See, how do you beat the examiner? By learning his psychology. And how do you learn the psychology of examiner? By learning his tools. His tools are in front of you, these questions. The more you study these questions, the more you understand the psychology of the examiner, and the more you understand the psychology, you will be able to beat the examiner at his own game. That's what I am training you for. That's what all the good teachers do. There's only one tool which will make you better. Practice as many MCQs as possible. You beat the examiner in his own game. It's like a game of chess, in fact. Anyhow, what is the highest oxygen concentration in fetal circulation? You'll find. First of all, you should know the fetal circulation will have placental circulation, and then you can try to find out your answer. Let me show you one diagram here. You see, this is a baby where you are looking at some placental circulation, and you'll find baby, the lungs are not functional. So mother's lungs are working, oxygenating the blood, and mother will send the oxygenated blood to the placenta, and from the placenta the oxygenated blood, let me take the green color, that will be better, will be carried by left umbilical vein. So this is the left umbilical vein which is bringing the oxygenated blood from mother to the baby, highest oxygen concentration. So we'll have the highest oxygen concentration in which vessel? Left umbilical vein. But then this oxygen concentration will be reduced as it passes through the lever to join the inferior vena cava. So when you reach the level of inferior vena cava, why the oxygen level will get reduced? Because what is basically inferior vena cava doing? Body below diaphragm, which is abdomen, pelvis, lower limb. So lower limb, pelvis, perineum and abdomen, all the venous blood, or you can say deoxygenated blood, who was carrying that? Inferior vena cava. So let me show you the inferior vena cava now. This inferior vena cava, which brings the deoxygenated blood from the lower limb, pelvis, perineum and abdomen, is mixing with the oxygenated blood. Obviously, the level of oxygen in inferior vena cava, which is, this left umbilical vein is joining with the help of ductus venosus embryologically. Here the oxygen concentration will go down. So here highest oxygen concentration, left umbilical vein, but it goes a bit slightly reduced. So still it is high, and this high level of oxygen, comparatively it is not very high, but this, where is this blood going now? Inferior vena cava will put it into right atrium, and right atrium will directly put it into the left atrium. Why you are bypassing the lung here? Because the lungs are not working in a baby. You have to bypass the lung, and as I bypass the lung, I use foramen ovale. Where this blood will go now? From left atrium to the left ventricle, and from the left ventricle where the blood will go? To the aorta. So from the aorta, where it will go? From the aorta it will go to the upper limb, subclavian artery, and the carotid artery, to the brain. In fact, the brain is the most important organ which will have requirement of highest oxygen. So mother, when it sends the high oxygen through left umbilical vein which get reduced in inferior vena cava, still carotid arteries will have enough oxygen. But now you see the aorta blood oxygen concentration goes down. Why the oxygen concentration is going down in the descending thoracic aorta? Because you see one other circulation. See, you have sent the arterial blood to the brain and upper limb, they'll send it back. Subclavian vein will bring the deoxygenated blood from upper limb, the jugular vein will bring it from the head neck. Where is this all blood coming? Superior vena cava. And from the superior vena cava, where this blood will come? So superior vena cava, as you see, which brings the blood from the head neck upper limb region, where this blood will go? Right atrium. And from the right atrium, where it will go? Embryologically it is directed into right ventricle. There is a crisscross of blood flowing. Can you see? Inferior vena cava blood is directed into left atrium by foramen ovale, but superior vena cava blood is directed into right ventricle, crisscross of the blood. So where the right ventricle will send it the deoxygenated blood? Obviously right ventricle will send it to the pulmonary trunk, and where the pulmonary trunk will send it to? Not to the lungs, because lungs are non-functional, they don't need too much of blood. Bypass lung. And how do you bypass lung? By ductus venosus, ductus arteriosus, and that is the blood which is coming into descending thoracic aorta. So obviously descending thoracic aorta will have now still low level of oxygen. The point is, you had highest level of oxygen where? In the left umbilical vein, high in the inferior vena cava, and then what about the descending thoracic aorta? It becomes low. Here it becomes low, and this deoxygenated blood, where is it going? This deoxygenated blood is of course going into iliac arteries, bifurcation of the abdominal aorta, and from there anterior division of internal iliac artery, and anterior division of internal iliac artery will send it to umbilical arteries, and umbilical arteries, these umbilical arteries are taking this blood into the placenta, and placenta will send it to the mother. Mother will again deoxygenate, mother will oxygenate this blood now. So the point is, where is the highest level of oxygen? Left umbilical vein. And where is the lowest level of oxygen? Of course, superior vena cava, lowest level of oxygen. Inferior vena cava, lowest level of oxygen. So maybe this will help you, or maybe the diagram which I am going to show now is a better diagram, and you can see the mixing of all the blood. So placenta sending blood, red blood, but then inferior vena cava coming from the lower limb, pelvis, perineum, abdomen, it gets reduced. Then it is bypassing through the foramen ovale into the left ventricle. Still some oxygen is there, because that oxygen is required for carotid artery and the brain. But if superior vena cava is sending the venous blood, where is this deoxygenated blood going? Directly into the right ventricle, from there into the pulmonary trunk, and pulmonary trunk bypasses how it into ductus arteriosus, into descending thoracic aorta. So descending thoracic aorta will have low level of oxygen, and then it is bifurcation into iliac artery, umbilical artery, and towards the placenta. So this is what you can see, this diagram telling you oxygen concentration. High oxygen left umbilical vein, and lowest concentration obviously inferior vena cava and superior vena cava, and moderate amount of oxygen, that could be pulmonary trunk, descending thoracic aorta, even umbilical arteries, moderate. So we are moving further, and yes, this kind of questions are coming. They give you some cut sections in anatomy, and then keep asking you some details like this is of course one anatomy question, but integrated with the clinical anatomy. This is one operative procedure some surgeon is working for cancer breast. A nerve has been compromised. You should know which nerves are at risk of injury when you're working for CA breast. Long thoracic nerve supplying serratus anterior is one of them. And if it is the one, difficulty overhead abduction. See, overhead abduction, two muscles are working, serratus anterior and trapezius. So this is a question on serratus anterior, because serratus anterior along with the trapezius is working, but trapezius is supplied by spinal axillary nerve, and spinal axillary nerve here, you are not operating here, you are operating here. So most probably the nerve supplied to serratus. And what is the nerve supplied to serratus? Long thoracic nerve of bell. If you want to ring the bell, doorbell, then what are you doing? Overhead abduction. Long thoracic nerve of bell, serratus anterior, it has been compromised. Okay, fine, but what is the structure involved? Of course, now you have to find out what exactly are they showing here. So let me zoom this, and as you see, what they are showing here is some muscles, and which muscles we are being shown here. As you notice, first of all, you have to orient yourself to the diagram. Skin, this is the skin. If that is the skin, what is this? This is the bone, the humerus bone. And along with humerus bone, you will find one more bone which is articulating with the humerus bone, glenoid cavity of scapula forming the shoulder joint. So this is the scapula, this is the humerus, they make the shoulder joint, muscles around the shoulder joint. Now there is one more bone here, the ribs. If this is the ribs, then what is this? This is thoracic cavity, you will have lungs here. So lungs here protected by the ribs, these are the ribs. Now if these are the ribs, this is the scapula and that is the humerus, you can orient yourself for the muscles because they are marking the muscles. These are the muscle fibers. What is this muscle which is around the humerus? Deltoid. So this muscle, as you see here, is deltoid. Now if this is the marker A, deltoid, which nerve supplies? Axillary nerve. So is it injury of axillary nerve? No. Then what about this marker B here? Marker B is a muscle which is shown dorsal to the scapula. And what is dorsal to scapula? Dorsal to scapula could be infraspinatus or supraspinatus. Now maybe supraspinatus, infraspinatus, whichever, it will be supplied by the suprascapular nerve. So is there a chance of damaging suprascapular nerve when you are operating on the CA breast? No. So will the infraspinatus be compromised? No. Then what about this muscle here? Coming from the ribs to the humerus. A large muscle, this is a small muscle. It is on the anterior side, pectoral major, under that pectoral minor. So pectoral major, pectoral minor. What is the nerve supply? The medial pectoral nerve. So could you have damaged medial pectoral nerve when you were operating for CA breast? Because mammary gland is here, you may damage. But is it so often damaged statistically? No. What is more often damaged is long thoracic nerve of bell. So finally, you reach your answer, marker C. And what is marker C? It is serratus anterior. And how do you know this is the serratus anterior muscle? This is serratus anterior muscle. We know because it is upper 8 ribs. It takes origin from upper 8 ribs and then insert into scapula, medial border of scapula. So this is serratus anterior muscle which might have been compromised. Marker C should be our answer. That is how we'll reach our answer. There is no other way we can prepare ourselves. There is only one way. Just keep practicing these MCQs as many as possible. And somehow, because this is a short session, cannot go into details, though of course I am working for PrepLadder and I am supposed to say buy the PrepLadder app and practice questions from PrepLadder. As a teacher, I won't say that. I'm a teacher, I'm not a businessman. But in this world, maybe you are a businessman or you are not a businessman, you have to promote something, you have to get associated with teams, and teams, if you are associated with teams, you have to follow the guidelines which the teams are, otherwise they'll say just go, why are you associated with us? So maybe that way, but anyhow we have worked very hard making the app, and I'll advise, if possible, go through the app, all the details are there, though I feel a little bit uncomfortable advertising things just like that. If you feel comfortable, go for it, and if you don't feel comfortable, what can I say? But I remember when I was in 12th standard, I was preparing for PG entrance exam. There used to be this institute, DPCC, Delhi Public College of Competitions, year 1993. Actually 93 I joined MBBS, 92. So I went to DPCC, I took the training, and that is how I became competitive, that is how I could join MBBS. So we have to spend some money actually. Nobody is doing any charity these days, though I would like to do charity if I had a lot of money behind my back, and maybe, but you have to spend some money. So spend the money appropriately on some good things, basically that's my purpose. For PG entrance I spent no money because there were no institutes, we used to prepare ourselves. Institutes came later for PG entrance. For PMPD there were institutes since long. Anyhow, so what do you think about this question? Again these are some repeat questions, maybe you already know the answer. Lesion of the marked nerve will lead to. Now the thing is what I am looking at first of all. They are asking wrist drop, could be radial nerve injury, claw hand could be mostly ulnar nerve injury, ape thumb deformity maybe median nerve injury. What is this claudication? Claudication means if there is some block in the artery, ischemic problems, and after some manual work I might have difficulty, pain, all that, claudication. So compression of an artery. So artery, nerve, three nerves, what exactly is this region? And maybe in your MBBS dissection you might have seen all those details. Let me take you into more details. So as I told you, these things might appear alien to you if you are looking at them first time, but since you have been practicing these questions, they will remain no more alien to you. So this is left cubital fossa you are looking at, and in the left cubital fossa just remember radial to medial you will have some structures, and just remember them are BAM. So radial to medial are BAM. Now what is this R BAM? What is R for? R is the radial nerve itself. So this is the radial nerve. If R is radial nerve, R BAM, then what is this medially? What do you have? M for median nerve. This is the median nerve here, this one. So if that is two nerves at the periphery, what is between the two? What is this B and A? B is the tendon of biceps. Here you will see this is the biceps muscle and the tendon is coming. Now if biceps, B is biceps, what is A? Artery. And which artery? The artery which comes here is brachial artery, where you take the Korotkoff sound and blood pressure and all that. So what are the two nerves at the periphery again? Radially you have radial nerve, and medially you have median nerve. And what is this tendon? Biceps. And what is this artery? The brachial artery. Brachial artery is bifurcating into two branches. One goes with the medial bone. Medial bone means ulnar bone, so ulnar artery. And one will go with the radial bone. Radial bone means radial artery. So as you can see here, this will be the radial artery and this will be the ulnar artery. Basically you are looking inside the cubital fossa here. What is the star marking? It is of course marking the radial nerve. And what will happen if radial nerve is damaged? Wrist drop. And what if the median nerve is damaged? If median nerve is damaged, then maybe you can have the features like ape thumb deformity. Ulnar nerve is not a content of cubital fossa. Why? Where is ulnar nerve? Ulnar nerve is actually passing behind the medial epicondyle. So here you can see this is the course of the ulnar nerve. And what is this elevation here? What do I see here? What is this structure? This structure is here, medial epicondyle, the lower end of humerus. So lower end of humerus you have medial epicondyle, that is the prominence here, and behind the medial epicondyle you have the ulnar nerve going. So ulnar nerve is not a content of cubital fossa. And what if there is a fracture medial epicondyle? Fracture medial epicondyle, of course you will have injury of the ulnar nerve resulting in claw hand deformity, ulnar claw hand deformity. So those were our questions. Anyhow, marker is on radial nerve, answer should be wrist drop. Now usually I lose track of time, so 5:20, we started at 4. I was given 1 hour, it's already 1 hour 20 minutes. I don't know how much tolerance do you have. Can you stay 10 more minutes? 10 more minutes. Just say yes or no. I don't know how much tolerance this people in the team who are projecting all these things. Normally I do it all myself, but today I wanted to focus upon teaching, not the technical thing. So there is a team with me. So I don't know how long can they stay with me, but can you? Okay, fine. So we can go for 10 to 20 minutes more. And as we see, let me take one question which is pertinent to our discussion, like this question. And you must know that, like one student was asking in the beginning, is it for FMGE exam? Yeah, this is one FMGE question only. So if it is FMGE question, then is it good for the INI-CET exam? Of course, there's overlap of questions. The standard might change, but pattern is same. So what is it asking for? And what question came in INI-CET recently? Let me show the details. You see, this question is asking muscle which is attached to arrow marked bony prominence. So what are we looking at? Front view of the pelvis. And what is this? Pubis symphysis. So a question comes, pubis symphysis is which kind of a joint? Secondary cartilaginous, that is what symphysis is. Anyhow, what is this prominence? They have shown the arrow mark, that is lesser trochanter on the bone femur. If this is lesser trochanter, what is this? This is greater trochanter. So greater trochanter, lesser trochanter. What is attaching to lesser trochanter? That is the question. So lesser trochanter, what is attaching is, we have to find out. These options are iliopsoas, gluteus maximus, medius, sartorius, like that. Let me take you to another diagram, then we can find out about the details of lesser trochanter attachment. Actually a muscle is inserting, a long muscle from lumbar region, psoas major. Along with that comes the muscle from ilium bone, iliacus, and together they are called as iliopsoas. So if you have given the latest exam, INI-CET, there was a question on psoas sepsis, TB spine, psoas sepsis. I'll explain that here as well. Now here, as you will notice, lesser trochanter we are talking about. So it is here, this is lesser trochanter. Now if this is the lesser trochanter, which muscle is inserting? See, from the lumbar vertebra come a muscle. It is showing it on the other side, so let us use the other side. From the lumbar vertebra come a long muscle, the psoas major. So this is the psoas major, which is coming from lumbar vertebra, and along with psoas major you'll find a muscle from the medial surface of the ilium bone. iliacus. Iliacus is also coming. So let me show the iliacus here coming from the medial surface of the ilium bone. Now if this is the iliacus and if that is the psoas major, then where are they both going? Here, that is what? The lesser trochanter. So this is what is shown here. Psoas major they are showing. Let me take it here to the lesser trochanter, and along with that they are also showing iliacus muscle. This is the iliacus muscle. Anyhow, what is this muscle doing? It's a simple rule. Any muscle which will cross the hip joint anteriorly is going to pull the femur anteriorly. And if you pull the femur anteriorly, what will happen? You pull the femur anteriorly, you are pulling the leg anteriorly. And if you pull the leg anteriorly, then what will happen? Flexion. Chief muscle of hip flexion, iliopsoas. So the question which came recently in INI-CET, actually it was All India PG question. There was a TB spine. There was some infection in the lumbar vertebra, that was tubercular spine, and cold abscess. That cold abscess was tracking along the psoas fascia, which cover the psoas muscle. So deep to the psoas fascia, but in front of the muscle, pus is coming. From the TV spine, some pus has come deep to psoas sheath, but in front of this muscle, this pus has come and it was making a swelling in the inguinal region, below inguinal ligament, in the femoral triangle. So in the femoral triangle, below the inguinal ligament, you found some swelling. Mostly it is miscalculated as, maybe misdiagnosed as lymph node swelling. But then it is actually the pus which has come from here. So that kind of questions keep coming. They in fact gave a coronal MRI picture, and there was some high density features on one side, psoas major, psoas fascia, psoas abscess basically. So they were talking about psoas abscess. The thing is that anatomy, if you read just anatomy, it becomes boring. But if you read anatomy along with the clinical application, it becomes interesting. Though in first year it may not sound good, but once you have passed your MBBS, then it becomes interesting. Anyhow, we have got our answer. That was iliopsoas, lesser trochanter. One other question has come, and it is a little bit confusing also. After reading Gray's Anatomy also, there is a lot of confusion. This question was, it is a repeat question, second time it got modified. It is asking, what is the action of the muscle on the hip joint, which is marked in this diagram. So as you look at this marking, what is this marking here? This is the head of the femur, neck of the femur, greater trochanter and lesser trochanter, but lesser trochanter is quite evident. You must be looking from posterior view. So posterior view of lesser trochanter, posterior view upper shaft of femur. What is this? There is a ridge, actually gluteal tuberosity. Now if this is gluteal tuberosity on the posterior aspect of upper femur, what is it for? It is insertion of gluteus maximus. Now gluteus maximus is a large muscle and only 25% fibers will insert here into gluteal tuberosity. Where is the rest 75% fibers going? Rest 75% fibers actually go into tibia. You mean to say that the gluteus maximus is inserted into tibia? How? By iliotibial tract. So 75% into iliotibial tract, yes. But anyhow, if you are telling it is gluteal tuberosity and gluteus maximus, what is the answer? Which is the muscle crossing the hip joint anterior? Iliopsoas. What does it do to the femur? Pull it anterior. And what will happen then at the hip joint? Flexion. Simple. a muscle which is attaching to femur posteriorly, it will pull the femur posterior. And if you pull the femur posterior, what will happen? Extension. It is an antagonistic muscle to iliopsoas. So gluteus maximus is antagonizing iliopsoas. Yes. If iliopsoas is flexion, this is extension. So let us find out the extension then. Where is extension? If you look at this options now, you will find that of course you have got the extension in somewhere, say here. Can I take this as my answer? No. Why cannot I take this as answer? Because it doesn't do medial rotation. Okay, if it doesn't do medial rotation, let me find out some other choice with extension. But there is no other choice with extension. Then what do? You should know the other activities of this muscle. And what are the other activities of this muscle? That's what. You cannot reach your answer until you have details. But let me tell you, because it is a muscle coming posteriorly, it can rotate the femur outside. Rotate the femur outside means what? Lateral rotation. Yes. Okay. So extension with lateral rotation. Extension is not there. Where is lateral rotation? This is. So can I take this as the answer? Can I take this as the answer? Because now I am stuck with choice A and C. It cannot be medial rotation, it can be lateral rotation. In lateral rotation also, it cannot be flexion because iliopsoas. So it's gone. This is already gone, and that is how you reach your answer. So is it doing abduction also? Is the gluteus maximus doing abduction? That is where you read Gray's Anatomy. It will tell upper fibers of gluteus maximus, they do abduction also. So what are the actions of gluteus maximus then? Of course, gluteus maximus, the first action will be hip extension. And what is the second action? Lateral rotation. Remember that all the gluteal muscles except two of them, they are lateral rotators. And what is that except then? And the plus upper fibers can do abduction. So let me, of course the answer is choice A, but let me give you some more details. It is always better that you are looking it from the anatomical perspective. Say this is the gluteus maximus. What is the origin? Origin is hip bone, ilium and sacrum bone also. So it is taking origin from the ilium bone and sacrum bone. Now if that is the origin from ilium sacrum, what is the insertion? 25% fibers into this gluteal tuberosity. Now if only 25% fibers are going into gluteal tuberosity, which is on the upper femur posteriorly, which is, you can show here, this is the marking here, and you are showing the muscle coming like this. What about the rest of the 75% fibers? They are coming here, iliotibial tract to the Gerdy's tubercle. There is a Gerdy's tubercle on the anterior tibia. So 75% of fibers insertion is into tibia, Gerdy's tubercle in the form of iliotibial tract along with the muscle tensor fascia lata. So gluteus maximus is a big muscle, tensor fascia lata is small muscle, but both of them together they insert via the iliotibial tract into anterior tibia at Gerdy's tubercle to stabilize the knee joint. That is also a function of gluteus maximus. But that was not our question. Our question was, if this is the muscle, what does it do? Since it crosses the hip joint posteriorly, it will pull the femur posterior. And if you pull the femur posterior, what will happen? It will be extension. The other thing is, you have to understand anatomically, the origin insertion. It can rotate the femur. And how can it rotate femur? This way. What is that way? Lateral rotation. Plus Gray's Anatomy says upper fibers, they can pull the femur like this. So if upper fibers can pull the femur like this, femur is going away from the midline, and if femur is going away from midline, what is that? Femur going away from midline, abduction. So gluteus maximus first action is extension at hip joint, number 2 lateral rotation, and number 3 it is abduction also. So all the glutei muscles, gluteus maximus, gluteus medius and minimus, they are doing the same thing? No, be careful now. Only gluteus maximus is a lateral rotator. Then what about gluteus medius, gluteus minimus? If you are talking about gluteus medius minimus, let me take you to this diagram, and according to their attachment you have to understand what could be their function. Remember, gluteus maximus attaches posteriorly on femur, gluteal tuberosity. If you remove this muscle, deep to that is gluteus medius. Gluteus medius attaches to greater trochanter laterally is one MCQ, and if you remove this muscle, deep to that, gluteus minimus attaches to greater trochanter anteriorly. So which is the posterior attachment? Maximus. Which is the middle attachment, or you can say lateral surface of the greater trochanter? That is medius. And which muscle is more anterior? The minimus, attaching anteriorly to the femur bone. So here you have to remember, gluteus maximus is a lateral rotator, but not the medius and minimus. Then what are they? Medius and minimus, just remember, abduction and medial rotation. They are rotating the femur medial. So is the gluteus maximus abductor? Of course it is abductor. We have mentioned upper fibers are abductors. So they are not lateral rotators. No. Why they are not lateral rotators? Because the axis they are working at, you see, maximus can pull the femur this way. So that is why it is lateral rotator. But the insertion of medius and minimus goes more anterior, and they pull it this way. You mean to say inside? Yes. You mean to say medial rotators? Yes. So abductor and medial rotators, and these two muscles are important for Trendelenburg test also. Whenever there is a problem with gluteus medius or minimus, Trendelenburg test will become positive, abductor mechanism become problem, and patient will walk with the lurching gait. That is altogether a different discussion. But the thing is, when somebody asks you which muscle is abductor, will you answer medius or maximus? Which muscle is abductor? Will you answer gluteus medius or maximus? Be careful. Maximus, the first answer is always extension. And what about abduction? You already told it was doing abduction. Yeah, maybe. But if somebody asks you abduction, you cannot answer it gluteus maximus. The first answer will be gluteus medius. So gluteus medius, abductor, first answer. If somebody asks medial rotator, of course gluteus medius, minimus. And if somebody asks lateral rotator, can you answer gluteus maximus? No. Gluteus maximus, the first answer is always extension. Maybe it is a lateral rotator, but if somebody asks you lateral rotator, you have to tell about the muscles which are deep to that. And what is deep to gluteus maximus, which I can answer as lateral rotator? There are so many muscles like superior gemellus, inferior gemellus, and then there is piriformis muscle and quadratus femoris muscle. So point here is, what are the three actions of gluteus maximus? Number 1, hip extension. Number 2, abductor. But is it the main abductor? No, main abductor is here. And what is the third action? Lateral rotator. So is it the main lateral rotator? No. Then who is the main lateral rotator? The one which are deep to that. So lateral rotators are short lateral rotators. Their names are piriformis, superior inferior gemellus, even obturator muscles are there, like that, quadratus femoris. So you have to just practice the MCQs. Lastly, the last question which I would like to take today is this one. Now you will be fainting by looking at this detailed question. Sir, what are you doing? Where are you getting all these questions from? Actually, these are all USMLE questions, you know. Our examination pattern is moving more towards USMLE. Okay, what is the question? Question is 74-year-old man. Now he is already 74 years old. Why are you tormenting this old man? See, he had undergone bilateral varicose vein stripping. Oh, varicose vein already stripped means which vein stripped? Tell me. I am not looking at the chat at all. Great saphenous vein, bilateral, yes. So you have removed both the great saphenous vein, yes. And then significant exertion, angina, now 74-year-old males having angina, and a positive treadmill test, and coronary angiography, and triple vessel disease, which is severe. Now obviously you have to do something for this gentleman. Underwent CABG, or you already have done CABG, coronary artery bypass graft, and taken saphenous vein. Which saphenous vein would you have taken? Because you already have removed great saphenous vein bilateral. So which saphenous vein would you have taken? Short saphenous vein. Okay. Now if you have taken short saphenous vein and put it for CABG, patient is not complaining lack of sensation on lateral margin of the foot. Which nerve supply lateral margin of foot? Sural nerve. And sural nerve is a branch of tibial nerve. What is the dermatome? S1. And why this sural nerve is having a problem? Because it runs along with the short saphenous vein. If it is running with short saphenous vein, then what is the relation with the vein? That's the question asking. So if it is lateral, then lateral malleus. If it is lateral malleus, then I am stuck with choice number C and D. Which one is the answer? That's what we will find out. So you might think such a big history, and then such a हिंदी में कहेंगे खोदा पहाड़ और निकली चुईया. So this is how the examiner is wasting your time. So take one hint from me. Whenever you find such a long question, straight away read the options first. First read the options, and that way you will have some orientation. What exactly am I going to focus upon in the question? Because sometimes it is all unnecessary information. It's useless. So such a long question, start with the options. Read the options first, and then you will know, okay, something to do with lateral malleus medial. Then you go through the detailed question. You don't have much time, 1 minute per question. So obviously, okay, so we are moving further, and this is what they are doing. Who is doing? The surgeon. And what is the surgeon doing? See, if you think that this is the patient, no, it is an actor. They have put one actor here and just shot some. So where are they working upon? See, this is the little toe, lateral margin. He is working on lateral margin of the leg and the foot. You mean to say short saphenous vein? Yes. Okay. If short saphenous vein, lateral margin, then little toe, of course. What are you doing? What I am doing is I will strip this vein and use it here. There is some block here, triple vessel disease, and I will take the vein, reverse it because it has valves. You have to reverse it because valves will prevent the flow otherwise, and I will attach this vein proximal to the block and distal to the block. Now why are you using the vein? You should use some artery. Of course arteries are used, internal mammary or internal thoracic arteries are used, radial arteries are used, but I have used the radial artery already. I have used the internal thoracic artery already. Why? How many arteries you want to use? Actually it is a triple vessel disease, multiple ischemic zones are there. So if arteries are not enough, you have to use veins, and you generally use great saphenous vein, but it was already stripped. Varicose veins were there. So short saphenous vein. Now if you have removed the short saphenous vein, you have improved the quality of life of your patient, fine, but what was the problem? Problem was that the patient is now complaining of some lack of sensation on the dorsum of the foot. Which dorsum of the foot? The lateral dorsum of the foot, sural nerve. So as you look at this patient, does it look like 74, 78-year-old? But this is maybe some Chinese person is there, or Japanese, they live long and healthy. So dorsum of the right foot. If you look at the dorsum of the right foot, you will find that we have a dorsal venous arch. So let us look at the dorsal venous arch. Right dorsum of the foot, this is dorsal venous arch. Now if that is the dorsal venous arch, what is it continuing medially as? Medially it will continue as the great saphenous vein. So this is the great saphenous vein medially. It lies anterior to medial malleolus. So this is great saphenous vein. What about this other vein which is going here? This is the lateral vein and this is short saphenous vein. So short saphenous vein is going where? Posterior to lateral malleolus. Now short saphenous vein goes posterior to lateral malleolus and great saphenous vein goes anterior to medial malleolus. What about the nerves? Nerves you can discuss. You will find that this is a nerve anterior to the one of the student was telling, sir, your videos have lot of cuts, and why is that so? Because I keep changing the pens, and in my recordings you will never find myself changing the pens because I delete all that. Sometimes I have to choose which pen to use, and in that only some 15 seconds are gone. That 15 seconds is waste. You are watching me changing the pen. Is it of any use? So I delete all that. So suddenly I is standing here, then I'm suddenly standing here. The student, what? Sir is disappearing and appearing. What is happening? Because I delete all those scenes where I change the pen. So what is the use of watching sir changing the pen, green, yellow, blue? It's all gone. In my videos, I change 100 times the pens. Did you ever notice me changing pen? They're all deleted. Anyhow, because the thing what I am showing should be evident, let me change it to green only. Green is better. So which nerve is that? See, this question will come. Saphenous nerve is a branch of the femoral nerve. And what is the root value of femoral nerve? Femoral nerve is L234. If it is L234, then which root value is with saphenous nerve? L4. And where is that L4? You can see here in this diagram, you will notice saphenous nerve, medial malleolus, medial dorsum of the foot. Now if you say this is L4, saphenous nerve, medial malleolus and medial dorsum of the foot, what about the lateral dorsum of the foot? Lateral dorsum of the foot, as we said, it is sural nerve and is a branch of tibial nerve. And what is the dermatome? Dermatome is S1. So tibial nerve, S1 dermatome, fine. And what is the relation with the short saphenous vein? That's what we will see. You will find that sural nerve is now starting here. Say this is sural nerve starting, and it will go behind the lateral malleolus, behind the short saphenous vein also. So finally what I wanted to convey, the message which I wanted to convey was, dorsal venous arch laterally continue as short saphenous vein, which can be taken for CABG, passes posterior to lateral malleolus, still posterior is sural nerve. So first you have lateral malleolus, then you have the short saphenous vein, still posterior is the sural nerve. What about the other one? Dorsal venous arch medially continues as great saphenous vein. Great saphenous vein passes anterior to medial malleolus, and what is still anterior to the vein is saphenous vein. In the Burns patient, when all the veins are collapsed, you will put a nick here, and when you are putting a nick here, then you will push IV fluid. Be careful when you are putting a nick here for IV fluid in the great saphenous vein, don't damage the saphenous nerve. Otherwise the patient will complain of sensory disturbance on the dorsum of the medial margin of the foot, and be careful, remember this clearly, saphenous nerve never reaches the great toe. Great toe, the dermatome is L5, just remember this, great toe is L5. Then what is saphenous nerve? It is L4. You mean to say L4 do not reach the great toe? No. Then what is the nerve supplying great toe? Be careful, if it is medial, then it is superficial peroneal nerve, which is also called fibular nerve. So superficial peroneal nerve will supply the medial aspect of the great toe. Yes, we will supply the lateral aspect of great toe. And as you see, if you are talking about the great toe lateral aspect, then this is a nerve which supply the dorsum of the first web space. And which nerve supply dorsum of first web space? And what is the dermatome? Dermatome is L5, both are L5. Great toe is always L5, but this nerve is deep peroneal nerve. So a question comes, which nerve supply the medial aspect of great toe? Your answer is superficial peroneal nerve. Which nerve supply the lateral aspect of great toe? Deep peroneal nerve. What is the dermatome of great toe? L5. That's all I wanted to discuss today, and thank you for all your patience. I don't know how many are left and how many have 6 dislikes. Okay, thank you very much. 361 likes. Thank you very much. And thank you for your patience. It's always a pleasure serving you, though I have become very old, 50 years old almost, 72 born, but I will persist for a few more years. This is very active job which we do actually. Then I will go a little bit less active format. Let us see how long can I survive with this much of efforts, but take it from me, I leave no stone unturned to put my best efforts, and I'm never happy or satisfied with myself, and that is the message I would like to give it to you. Never be satisfied with your performance. Your true competitor is you yourself. I prepare some slides and I'm very happy today, and as I get up in the morning I am so sad, this is such a poor slide, let me improve it again. And this perfectionism never dies, and it is very painful for my family, because they say, what, all the time this man is just perfecting his slides. So my best wishes, blessings to you all. Just tolerate us people, old people, some eccentric people, but I am very sure if you could tolerate us, will make very good physicians out of you, very good surgeons out of you. And study is for 2 purposes. Number 1, you have to use the study in your life as a professional, and number 2, you have to pass the exam also. We train you for the exams, but in the process, if I do not train you to become a better physician surgeon, then I am failing my mission. So my main mission is to make you better surgeons, physicians, and of course in the process you will score better, of course. An anatomist with clinical knowledge, it's a rare thing, but since I am more of a doctor rather than a teacher, it will always help you. Thanks a lot for giving me a chance, and God bless.